Welcome, everybody, to the Whole Person Healthcare Integrating Behavioral Health into Primary Care webinar. We're delighted to have you here. My name is Steve Malik. I am the moderator and a very short introductory speaker for this webinar, and I am a consulting actuary with Milliman. So I've been with Milliman for just crossed 30 years. And the vast majority of those years, I've been involved either a little or a lot in the behavioral healthcare space as an actuary, mostly focusing on financial things, but sometimes I get a little involved with clinical or operational aspects of behavioral healthcare. But my co-panelists here are much more informative on that front. So I'm going to let them introduce themselves. They're all doctors. We've got Sherry, Vaughn, and Brian. So you want to introduce yourselves in that order, folks?
Thanks, Steve. Hi, everyone. I'm Sherry Kirschenbaum. I'm the clinical director at Quartet Health. Quartet is a technology and services company on a mission to improve the lives of people with mental health conditions by making it easier for people to get the mental health care they need. I'm a licensed clinical psychologist, and the thread that runs through the work that I've done is really around improving health outcomes for hard to reach and vulnerable populations through integrated care practices. So I'm really excited to be here today with all of you.
Thank you, Sherry. Vaughn, you next.
Yeah, thank you, Stacey. So my name is Vaughn Nguyen. I'm the Vice President of Clinical Operations and Innovations at Blue Cross in North Carolina. So I'm in charge of a number of things, clinical operations, but one of the aspects of the work I do is centers on the idea of behavioral health and the strategy we're trying to run alongside this. In North Carolina, we're trying to do something quite different, which is trying to spread value-based care across the entire ecosystem here, and really thinking differently about how we pay for care and incentivize providers to really think holistically about that person. As we're doing this, there's a clear recognition that it's impossible to achieve the outcomes you want without thinking of behavioral health and the physical health together as one sort of entity and really driving the incentives such that we're able to address both problems simultaneously. But in North Carolina, this is what we're doing. And as far as my background is concerned, in addition to being the vice president here at clinical operations, I happen to be a primary care doctor and a physician as well.
Excellent, thank you. And Brian.
Hello, my name is Brian Klosner. I am a primary care physician. I work for Wake Med Hospital in Raleigh, North Carolina. I have a area of focus or interest specifically with homeless medicine. I've been involved with homeless medicine really since I started my career as a physician. At Wake Med, I'm in a primary care clinic downtown, but also serve as our chief medical officer for our accountable care organization, which is a partnership between Wake Med, which is kind of our community safety net hospital in Raleigh, and then Key Independent Physicians, which is a group of fiercely independent, 350 independent physicians in the community. We formed ACO together, and that's been incredible and a whole lot of fun. And then my last position is I direct for our hospital, our high utilizer program, or what we call a hotspotter model. So in North Carolina, we're in a state without Medicaid expansion. And so we have a high risk of vulnerable, uninsured homeless patients, usually homeless patients. And so we have a case management team that will outreach and engage with them. And obviously in that population, you have a high prevalence of mental illness.
Well, thank you. So this is the way this webinar is going to work. We have no slides. We are going to have discussions, or some people like to say storytelling. And I'm going to introduce a segment with a few different objectives and ask questions, and there'll be a lead that I'll direct the question to, but any of the panelists can jump in at any time. And of course, if through the webinar, a question pops to your mind, there is a Q&A section for you to type that question in, And we'll get to the Q&A section in the last 10, 15 minutes or so of this webinar. We will try to stay on time. We've got 3 different sections in this discussion. First section is the burden of mental health disorders. The second has to do with integrating behavioral health care and value-based primary care. And then the third section is a bit of an open one called emerging opportunities. So I will be leading, I'll be asking the questions. Yeah, probably won't have a lot to add, but I might in the discussion. But to kick us off, I wanted to take about 2 minutes to summarize a report that we did that has to do with the need for integrated medical behavioral care and some of the findings of an analysis. As actuaries, of course, we like to play with numbers a lot. So we have a database of commercially insured detailed claim data for over 20 million insured lives. And we got asked by one of our clients to do an analysis of the top 10% of, I'm hearing a buzzing in the background. I hope that's not coming from my end. Top 10% of all of individuals based on cost. So of the 20 million lives we analyzed, that's 2.1 million. The average cost annually for the high cost group turned out to be over $41,000. And compared to the not high cost group, or the other 90%, the high cost group was more than 21 times higher from a cost basis. So it's really high cost. So that top 10%, the 2.1 million, within that group, 57% of the people, starting to approach 2/3, either had a diagnosis for a behavioral health condition in the claim data or actually received behavioral health specific treatments, services, prescription drugs, or both. So high prevalence of behavioral conditions in the top 10% of users. The interesting finding there is that the amount of spending on behavioral health care within that top 10% was very often very low, like $100 per year or less. So maybe just one script or a couple of sessions to a therapist or something. The only high costs in that would have been those that were hospitalized. So what's interesting is that when you look at the total population, the 21 million across the board, we saw a 27% prevalence rate for people that either had a behavioral health condition or were receiving treatments for their behavioral condition. And that 20% of the population accounted for 56% of the cost. So even within the whole population, the takeaway is people with behavioral conditions use a lot of healthcare. A significant majority of the total healthcare costs come from people that have a behavioral disorder, and very often it is comorbid with chronic medical conditions, diabetes, asthma, heart disease, et cetera. So to me, from a financial perspective, and the doctors here will talk about the clinical, operational, and patient perspective, the importance of considering and hopefully implementing coordinated care, collaborative care, integrated care, whatever you want to call it, getting behavioral health care available to people that commonly have physical health conditions, either in just outpatient settings or emergency departments or hospitals. So I will stop there and we will start segment 1, the burden of mental health conditions. So the objective of this section is to discuss the clinical and economic burden of mental health disorders and substance use disorders and the impact of the COVID-19 pandemic. So just see if we're all on the same page. There really is a difference. A lot of folks are adopting the term behavioral health to include mental health and substance use disorders. And a good friend and colleague of mine, Dr. Ben Miller, who was at the University of Colorado and now he's out at Wellbeing Trust in California, once told me that there's a difference between mental health and mental illness. We all have mental health. And all of our mental health is being taxed during the pandemic. It affects us in different ways. Sometimes we're a little bit anxious, we're a little worried, we might get depressed, we might just have bad days. And it's okay to not be okay during this pandemic, as long as we can all bounce back and support each other. And that's so important. But when mental health is so taxed and stressed, it can lead to a mental illness. And that's when you actually need treatment from professional providers like those in our panel. So there's direct costs and there's indirect costs. If you have a behavioral disorder, direct costs can include disability costs, healthcare costs, certainly, the cost of being away from work, could include the cost of taking care of your family, et cetera, et cetera. So there'll be additional discussion of the indirect costs as well. But I just wanted to throw out one set of numbers just to give you an idea. And I'll choose uncomplicated diabetes. So an uncomplicated patient with diabetes incurs about $1,000 a month in total healthcare costs, $1,000. Layer on a mental disorder, a not serious mental disorder, but maybe it's a low-grade depression, that $1,000 jumps up to about $1,600 in cost. And if it's a serious and persistent mental order, it jumps up to $2,000, and substance use disorders, $2,100. So when you go from $1,000 to, let's just say, $2,000 for the sake of discussion, you might obviously think, well, it costs $1,000 to treat the behavioral disorder on top of the $1,000 to treat the diabetes. No, that's not what it is. Out of that extra $1,000, maybe $200 is to treat the depression, the anxiety, the substance use disorder on average per patient. The other $800 is exacerbated costs of the chronic condition. So the diabetes cost gets worse when somebody has a behavioral disorder. And it's easy to understand because if you're depressed and you have diabetes, you might not be doing a whole lot of self-care for your diabetes. So you have more incidents in emergency departments, more hospitalizations, perhaps more readmissions for hospitalizations, those kinds of things. So the importance of integration is clearly spelled out in the cost data and analyses that these patients get to be real expensive, real fast. And from a financial perspective, it makes great sense to try to approach integrated care, collaborative care, whatever version you have of introducing and delivering both physical healthcare and behavioral healthcare together. So I'm going to throw this first question out to Brian. Can you discuss the typical patient journey for an individual with a serious behavioral disorder, such as major depression? Could you provide us with a journey discussion there?
Yeah, I think I'll highlight a lot of what you just said. That a lot of times that journey is relatively silent. A lot of times we're not doing a good job screening and identifying and seeking out mental health disorders in the primary care clinic. So there's a lot of suffering that is primarily silent, but it can be extremely expensive. So you can't treat effectively what you don't screen for. And when patients are interacting with primary care or just medicine in general, there isn't a fifth vital sign. There isn't an objective physical exam finding. There's not a lab finding that says this patient's depressed. And then a lot of times there's a stigma around mental illness. And so the patients are actively trying to hide it from providers. So it's amazing. And I think the study that you highlighted just puts numbers to this, how big a problem that is and how much really expensive suffering we're tolerating as a healthcare system. And so often, when we see a lot of patients who are in the emergency room 9, 10, 11 times in the course of a month. And their diagnosis is chest pain and nausea and vomiting and ankle pain. And, And really, when you look at it, the underlying cause is mental illness, but that's never diagnosed, that's never treated, that's never addressed. And so often that journey of severe mental illness is really pretty silent, hidden from a medical community that doesn't actively seek it out. For those with mental illness that we are able to identify, for those that we do screen or do come to present with us, the majority of mental illness falls on primary care to manage, and we can't effectively manage the vast majority of mental illness, depression, anxiety. We're able to manage in our primary care clinic. But for those that with more complicated disease or that we're not able to treat in the primary care setting, a lot of times it can get very disjointed. There's kind of often in most communities, I think, across the nation, there's a disjointed safety net of mental health providers and clinics. And it can be really confusing for patients, and it can be really expensive for patients as well. A lot of patients can't afford the copay. There might be issues with their insurance. They're not covered at a certain clinic. A lot of times, especially with therapy, we see some confusion where they get referred to this specialist, but this specialist really doesn't focus on marriage counseling. It's more job stress. And there's a lot of disconnects as we're trying to navigate patients through mental health safety nets in the community. Those safety nets tend to be disjointed and confusing, therefore exacerbating the mental health that the patients are suffering with in the first place. So there can be a lot of confusion. There can be a lot of cost associated with it, and just a lot of sustained suffering that equates to high costs, as you said in the study, but just basic human suffering that we're not really getting at, especially with the more severe mental illness.
Great opportunities there. Couple questions for Vaughn. For people with health insurance, can you talk about some of the barriers to access of behavioral health care for them?
Yeah, for people with health insurance, I mean, I guess just to state, first of all, there actually are many people without health insurance. And so cost is one of the critical barriers to getting appropriate behavioral health service. So independent of that, there are lots of different ways you can pay for healthcare, whether it be an FQHC, where frequently there are behavioral health services, and sort of a sliding scale. There's Medicaid and other services. So cost is clearly one of these barriers in a very meaningful way. But even when you have insurance, I think there still remain barriers to getting the appropriate care that you have. And when you think about this, there's a question of how providers are actually incentivized to think about healthcare or think about behavioral healthcare. One example I'll mention, sort of allude back to Brian's comment. So the vast majority of behavioral health conditions will actually present to a primary care provider. But again, there's this stigma, and frequently it's not easy to diagnose. So how do you create incentives for providers to start asking the right questions to make sure they get to the right, to begin to diagnose? It may be sort of incentivizing the use of a PHQ-9 to sort of begin to ask the right questions. I think one of the really interesting ways to think about this is actually one of the barriers in terms of the stigma is to really think about solutions, and I'll ask Sherry to comment on this, to think about how you might identify those who have underdiagnosed, the population of underdiagnosed behavioral health services, or who might need behavioral health services but underdiagnosed. And there are lots of really new, unique, interesting ways to do this, and I think Quartet has one of those great solutions. And it overcomes that barrier of stigma, where I, as a patient, might be really reluctant to tell Brian about my behavioral health services. But there are other ways to begin to identify who these individuals might be and what services they might need.
So one additional question for primary care physicians, how has COVID-19 affected their ability to work with behavioral health doctors and those that need behavioral health care services? Has the COVID-19 affected the potential for primary care and specialty care to work together?
Yeah, I would say I'm seeing it in my clinic right now. I think if you combine the study that Milliman did that you talked about with the CDC study that came out pretty much the same time, mid-August, that showed that the prevalence of anxiety and depression have tripled with anxiety, quadrupled with depression. So prevalence usually like 8% in the community and the society. And now it's gone up to about 24, 25%. And again, the vast majority of that's going to fall in primary care. And so it's compromising an already compromised system, right? That we were already struggling to identify, treat, and address mental illness. And I mean, I especially in the past month, it's not overwhelming, but we're seeing a ton of mental illness in the primary care clinic. So, if anything, we always knew, for the reasons you discussed in the Millman study, we're not doing a good job managing mental health. And there's a human suffering component to that, and there is a cost associated with that. We need to do better. COVID has just highlighted kind of a sense of urgency of we really have to put these things in place. And we have had Quartet implemented. Thankfully, we implemented last year. And so that's really a tool and resources we've been able to leverage during COVID. But it shined a very bright light. And we're going to be stuck with this for the foreseeable future, for the next at least 1 or 2, 3 years. The consequences, the mental health consequences of COVID is really just shining a much brighter light on the need for us to expedite, to address these issues, to have honest discussions about why we've kind of stunk historically. Like what have been the barriers? Why haven't we addressed it? And I think to Vaughn's point, one of the barriers, honestly, is one of the reasons we're not screening. Be careful what you look for in case you find it. If we identify mental health, if we don't feel empowered to treat it, if we don't have the resources to treat it, that steers a lot of primary care docs away from screening and treating. So hopefully COVID is dramatically stressing an already inefficient system, but hopefully it leads to change around this where we all admit as primary care docs, we have to do this better to control costs, to minimize outcomes, to control chronic disease. I think that's a really important point that you brought up, Steve. My job is to control diabetes, heart disease, depression, anxiety. But if a patient has severe mental illness, a lot of times it's an exercise in futility to try to treat the diabetes and the heart disease if I don't work to treat the mental illness. So we've known we've had to do it for a while, and hopefully the events of 2020 collectively have shined a brighter light on how we need to move quicker on this. Right.
Yeah. So basic economics here, the demand is going up. The supply has been flat or going down. We have an all-payer claim database here in Colorado, and there's a presentation across all the payers about the use of teleservices and specific subset telemental health services. And in March and April, it skyrocketed. So the question for the entire panel is, do you think it's good to have such a large increase, if you assume that it's happening in your area as well, of teleservices, video or telephone, and talking to mental health folks about all these stressors that are happening, resulting from lost jobs, a school at home, too much family time, whatever else is stressing everybody now. Is the increased use of teleservices for behavioral health care a temporary thing, or is it a new way to offer services that's, especially if it's paid for properly, it's welcomed and may be here to stay? For the whole panel, anybody that wants to respond.
Yeah, I could kind of jump in here. I think that there's been a really amazing kind of change in access to behavioral health services through telehealth, that has been pushed by COVID. I think we've all been pushed to really accommodate and be able to provide safe care and effective care to patients. Whether it will continue or not is, I think, really going to depend upon the liberalization of all of the regulations around telehealth services. So both private payers and public payers have done a lot to make audio and video available to more people, to make them paid at parity, to decrease some regulations around originating sites, so that more people can really access the care that they need. And patients have really been able to benefit. There's, a lot of challenges in doing that, but Quartet's really worked hard with our partners that we're talking with here today, we'll be able to increase that. Only referring patients to providers who have the capacity to see patients via telehealth, and really being able to provide also digital care options for people. So not just tele, but computerized CBT, doing some partnerships with Silver Cloud Health to be able to get digital care options around stress and anxiety and depression, both to patients as well as to providers. So we launched a kind of a care for caregivers initiative through Quartet, because we know that because of such increases in mental health demand, our caregivers are on the front lines. So it makes it really challenging for them too. So we did a lot of partnership with Blue Cross North Carolina and did webinars for providers to decrease burnout, to kind of get up to speed and up to snuff on how to deliver telehealth services and really be able to understand all of the changing landscapes of regulations too.
Yeah, and I would chime in and completely agree with Sherry here. When you look at the numbers at Blue Cross, we've seen a 7,000% increase in telehealth from this time last year. So not 700, 7,000 time increase. So remarkable increase. A couple things I would say about this. So yes, we hope it's here to stay. I think we're actually just in the beginning of what the opportunities might look like. And Sherry began to describe some of the new opportunities, not just like the telephone call or the video, but really the cognitive behavioral therapy, digital techniques, sort of opportunities to leverage the technology that we have in front of us in a much more meaningful way, to think very differently about the best way to engage patients and members in the way that they want to be engaged. You know, and as you can imagine, like today, in today's digital age, that's frequently not the telephone. And there are other ways to do that. Like, when was the last time you picked up a phone from a number you didn't recognize? So really thinking differently about telehealth and really thinking differently about the opportunities here, I think is critically important. And then subsequently sort of wrapping this in to not just think about the phone calls and the videos, but sort of what are the other services that might be important? And how do you link this, not just from the behavioral health side, but also to the physical health side? You can imagine sort of remote patient monitoring for cardiology, and then we can toss in behavioral health visits somewhere in between. Lots of different opportunities here to really think differently about how these services are delivered.
Yeah, and I would chime in too. If it's not here to stay, then we're extremely inefficient, right? So if based on all these studies that we're seeing, if we don't control mental health, we're not going to control medical costs, right? So if I'm a payer, I'm going to much better control my medical costs if I control behavioral health. And then you look at the studies around telehealth. And I remember actually, Vaughn, the first time I really heard about this was a couple years ago through Blue Cross Blue Shield of North Carolina. And one of your PPs was talking about a study that showed that telepsych was as effective in a lot of studies, especially in younger populations, as, you know, being in the office on a couch, in-person therapy. And at first I was surprised by that, but then I thought about it and it doesn't surprise me at all. It takes that stigma out of seeing a mental health provider. You don't have to walk into a behavioral health clinic. And so often behavioral health is so community-based. The pathologies around the stressors, everything is so community-based. If you meet the patient in their environment where their pathologies live, it's going to be more effective and they're going to feel much more comfortable. So any steering away from a continued support and financial reimbursement for telehealth would seem to be just horrifically ill-informed, both from a patient care perspective, but also from just a economic perspective. I think between two things, telehealth, and then if payers can get rid of the behavioral health copays, do not view behavioral health like a specialty visit, and do not create barriers to getting the mental health they need because you're going to pay for it if you do. Between those two things, I think if we're able to do those two things from a behavioral health approach, from a payment design perspective, I think we can get to a lot of the historic barriers. Patients don't show up to clinics. Patients don't like to go to psychiatry clinics. Patients feel, especially younger populations, feel much more comfortable a lot of times, not universally, a lot of times with telemedicine and telepsych. So that's something we have to continue. And I think we really have to call it out if that's not continued post-COVID.
Yeah,
great discussion.
As we think about sort of the way to pay for care and value-based care, this is one of the great opportunities, meaning that as you think about the way we pay for care now, it's sort of a fee-for-service work where you produce a widget, we pay you for the widget. And as you can imagine, like the cost of healthcare is kind of high, and really thinking differently about changing that dynamic is actually critically important. So I can imagine a world where we work with psychiatrists or behavioral health specialists and say, hey, this is what we pay you on the front end. You need to take care of the patients. Let us know what you want to do. And within that context, we really defer to you because you are the clinical experts and you have the patient right in front of you, and paying in a value-based way to give providers the flexibility to take care of the patients the way they want. One caution, however, I think, as you think about telehealth, though, is one interesting nuance that I've been talking to some of my behavioral health specialist friends is that we still need to learn quite a bit about this space. One specific opportunity might be thinking hard about the value of video service versus telephonic only services. And are they actually equivalent in terms of the quality of care that you may achieve? Because it's really hard it's really easy to have a therapeutic relationship when you can see your provider and the patient on the screen with you. Simultaneously, the patient may be actually in the grocery store and picking up a phone call, or dealing with their children because it's COVID, because everybody has their children home like me, and trying to have a therapeutic relationship. So really thinking through and understanding, doing more analysis to figure out what works and where do we achieve the highest quality outcomes. Really driving that would be really critical. And I think that's a great opportunity to partner with Quartet in terms of gathering and looking at the data, and also with providers in terms of understanding what their needs are.
Thank you.
Oh, sorry, Steve. I was just
go ahead.
Thinking about matching patients to the right care that's appropriate for them, and the clinically and what the patient's needs are. So that relates to what Vaughn was talking about too, about audio versus video, and which patients might be appropriate for which modality. I'm thinking about some high-risk, high-need patients where it might be more challenging. Always needing to have crisis plans for patients when you're working in tele. But I definitely see a lot of benefits too, but agree that there is definitely more to be learned. There are benefits in terms of reduced no-show rates, increased access, and there's also some interesting data around patient acceptability of the modality. And some studies show that patients feel more comfortable than providers. And there's this kind of concept of providers as gatekeepers. And if we could work with providers and support them more and get them feeling more comfortable with the modality of teleservices, that would usher more patients to increase their comfort as well.
So we've kind of gotten into the integrated care for patients. Maybe we call it whole person care for their physical needs, their behavioral needs. And pre-COVID, that could have happened in an office. And I'd have walked in, and when I got escorted into a treatment room, I'd sit in a chair or on a padded exam table for primary care and vital signs and stuff like that. And either in that kind of setting or in today's setting where there's a lot more tele use, let's talk about how it actually works in practice. How would an integrated care visit, either physically in person or on the telephone, how would it actually work and work well? Who would like to address that?
I can start. I mean, I had the benefit of working in a true integrated care model that was developed up in Boston. My first job was with Boston Healthcare for the Homeless. It was me and this incredible psychiatrist next to each other in the clinic. And it was so much fun. It was so awesome. And these are extremely high risk, high cost, severe mental illness patients. But it was incredible. It made a ton of sense. And these patients, their costs were in the hundreds of thousands. Like it made all the sense in the world. Most primary care practices can't financially or logistically swing a true integrated care model like that. They can't afford or support actual mental health embedded into the clinic. Some can, the larger ones can, but for the most part, you're not able to do that. But so the key is, how do you do that? How do you get that same sense of collaboration through with not having to be actually in the clinic? And I think the key is just to make sure that if I'm the primary care doc and there's a psychiatrist, that we're communicating together and that we're coordinating with the plan and that we're following through with the patient. And that is why I do think one of the reasons we've been really utilizing and supporting Quartet is because it does that. It ensures that a referral is made. It ensures that it's a good match. It ensures that there's follow-up and it tracks that. And so I think you're never going to be able to implement in all the primary care clinics true on-site integrated care models. And that's really what Quartet tries to solve, is it gives us that capability without actually having to be, physically in the same clinic with the psychiatrist. To your point, Steve, I think there's a lot of potential, especially that's where you get excited about telehealth. I mean, that's not unrealistic. I do that still with some of my homeless patients with the psychiatrist that I work with right now, that she can be on the phone with them, I can be on the phone with them. Very powerful to have the patient see us together as a team. They feel much more supported. That's probably something. And it would parallel the same benefit that my homeless patients got 14 years ago when they saw me and the psychiatrist, Dr. McGahee, together. It feels like they're supported by a team. I think there's potential to do that with these modalities, including Quartet and the telehealth capabilities that they have.
Great. Any other thoughts?
Yeah, what I might add to this is when we think about this at Blue Cross, we think of it as like paying for care differently, and then making sure that we have the enablement tools to support providers in that context. So first, let me talk about the payment a little bit differently. When you think about the primary care side, we're working quite hard to work with providers like WKCC to be part of ACOs. So when you're an accountable care organization, Brian and his team actually get paid for keeping people well. Like the shared savings is for keeping people out of the hospital as opposed to sending people to the ER. So there's an incentive there for Brian and his providers to do their best to keep people well. Simultaneously, we have a separate program called Blueprint Behavioral Health for behavioral health providers, where we pay based on a fee-for-service rate, but also on quality. Like if you achieve certain quality metrics, then subsequently you get paid more. This quality metrics center around a couple basic ideas. One is like engagement. One of the challenges with behavioral health members sometimes is it's sometimes hard. They'll fall through the cracks if you don't follow up with them regularly. So really incentivizing providers to sort of reach out to them and make that connection and grab a hold of them and really enter that therapeutic relationship. Thinking also about engagement in the terms of, I can incentivize a behavioral health provider for like utilization of medications or antidepressants, but also thinking about, well, if this member has a substance use disorder, it'd be really great if we also incentivize screening for HIV, or thinking about the physical health side by screening for hepatitis C as well, as part of the quality metric that we encourage behavioral providers to think about. So incentivizing providers to think about not just their world, but the world around them and the other parts and their partners in this, and how to take care of patients. Then when you have the incentives in place, you move into this world where you think about the enabling strategies. And this is where I'll ask Sherry to say a little bit more about the work they do. But I think Quartet is just critical, very critical in terms of connecting the physical and behavioral health. Really, towards Sherry's point, this idea of understanding the right service that a patient might need at a given time. Is it a psychiatrist, or is it a counselor, or is it a peer support network that they really need? Really understanding that dynamic, and then using the data available to really make that connection in a meaningful way, and following up in a meaningful way too. But I'll defer to Sherry to say more about the model, but really great collaboration, I think, between a payer, a provider, and Quartet to really integrate behavioral health care.
Yeah, I could chime in here. Thanks, Fawn. I feel like it's exciting to talk about this partnership with all of us here together. That doesn't happen very often. So I could give folks a little more information about the Quartet and how, we, talked just a little bit ago about, this kind of ideal integrated care model with the person in the room. And, Brian talked about his experience and how that's not scalable always. It's not possible to do. It's really costly. We don't have the sheer workforce of mental health providers to be able to kind of do that. So that's what Quartet does. Quartet is able to kind of ensure, both with technology and services, that people get the mental health care they need, and in a number of different ways that Vaughn is just kind of talking about as well. So being able to reach patients that need care. So being able to identify patients and also be able to engage them. Brian was talking about problems in primary care with kind of identifying patients often who actually have mental health conditions. And, Steve, when you were talking about the Nguyen report at the beginning, sometimes we're not always aware of the patients that are kind of costing the most and in the emergency rooms with underlying undiagnosed mental health conditions. So we really kind of set out to be able to help to be able to do that. And people could be referred to Quartet through their primary care doctors, case managers. And then we're also able to, with our machine learning algorithms, be able to utilize claims data and be able to identify folks with unmet needs. So another thing we do that I mentioned before is connect people to the right care. So this is really based on patient preferences, looking at clinical need, their insurance, and having that broad array of care options, so psychiatrists, therapists, teleservices, CCBT. And as Brian had mentioned, primary care docs are seeing a lot of patients with mental health conditions and treating them in the primary care setting. So really leveraging things like curbside consultation, where we could have through Quartet, PCPs reach out to a board certified psychiatrist and get some consultation and support for patients they might have questions about. Maybe they feel comfortable treating those patients in the primary care setting, but need a little bit more support. So we're able to do that. And then to kind of help support a value-based care model, you need to be able to think about tracking quality of care. So we're able to, I think in general, we need to think about being able to measure mental health as robustly as we measure physical health. That's something that's been, I think, historically really problematic. So Quartet really helps to enable data collection and measurement and tracking for identification of patients for an APM model in collaboration with Blue Cross, and setting out what those metrics are and how to kind of collect the data. And also through our assessment tools, we kind of curated a really appropriate and broad assessment library for people to be able to utilize to track outcomes for patients with a variety of different mental health conditions. And then kind of the last component to the model is really to make sure that people are supported in the care journey. So being able to provide a HIPAA-compliant platform that really serves as the foundation for that collaborative care, where mental health providers, where primary care providers, Brian and his team could communicate together and have a shared patient timeline, share patient treatment plans, and really kind of virtually scale that collaborative care model. And then for people who need that personal touch, we have at Quartet a dedicated team of care navigators that is able to really talk with patients and help them through the care journey if they need that. So, really a collaborative kind of support and efforts from all of our perspectives. Yeah. And Brian and Vaughn, please chime in on as we kind of all work together on this.
And I would say, the best thing I can say, and I have no vested interest in Quartet. I think it's an incredible platform. The best thing I can say is that I haven't heard a lot of it from our providers. So we've been utilizing it a ton. People are very appreciative. I say, how's it going? They say, it's going great. It's very easy to use. And that's key. You have to make these things provider-centric. You have to make them easy to use. And they have confidence that when they make a referral, it's going to be a good match and that the patient is going to be seen. So it's been very easy to implement. We're seeing our numbers keep increasing, which is awesome. And then to Sherry's point, the predictive analytics is nice. We need to get more proactive with this. Because of the stigma, because of those issues around the patients just not liking to talk about these things, to get a list from Blue Cross and say, hey, these are your patients that might be suffering from mental illness, be more proactive and outreach and talk to them and screen, that's going to be the solution. And we only have had a couple practices that have implemented the approaches with the predictive analytics, but they've really liked it. I mean, these are the patients that are suffering 3, 4, 5 times the medical cost. They might not be coming in saying I have depression or anxiety, but really try to dig into that and explore it. That proactive nature, I think, is absolutely essential if we're going to do this better.
That's great. So I'm going to remind the attendees, we're getting close to our Q&A section of the webinar. So you can submit questions that you have on your mind for anything we've talked about or anything related to integrated care. The last question I want to ask the panel before we get attendee questions is, okay, so you've made advancements with integrated medical behavioral care. What's next? What's the next thing you want to add to your system, to your practices, whatever locations they might be, primary care, emergency departments, other, what's the next good thing to add on to even make the integrated care better for achieving the triple aim, quadruple aim objectives?
I guess I can answer as a primary care. I think, first of all, we're just very early on in the Quartet process. And so better utilizing, implementing that and working our patients toward it, number one. Number two, what I just discussed about the more proactive nature. Let's screen the patients in front of us, but let's look at our patient panel and say, okay, who might be suffering from mental illness and who should we reach out to? Number three, I think, is really kind of the telehealth and is trying to explore more of that. Can we truly bring in an integrated process by joining in from a telehealth perspective and outreaching to patients? And then the fourth, I think, is pediatric mental illness. Is as we advance this, the pediatric, when you look at your study, Steve, I don't think it incorporated a lot of a pediatric population, but the ROI, the immediate ROI isn't probably going to be there to the extent that it is from an adult perspective. But from a long-term ROI, from a long-term, impact, if we can better manage, if we can better screen for and identify pediatric mental illness and actually impact it, and COVID is disproportionately affecting younger populations when you see the uptick in depression, and anxiety, and especially around suicidal ideation.
Yes.
If we can better do that now, we're not going to get slapped in the face with this huge ROI like we're probably going to do from an adult perspective. But the long-term cross-generational benefit, both from a patient suffering perspective, but also from a cost perspective, is going to be huge. So right now, population health is very focused on this year, next year, reducing costs, quality measures. But if we can get a broader view of that and say, wait a minute, how can we better address pediatric mental illness, similar to what we're trying to do from mainly from an adult perspective? I think that's going to be huge.
Yeah, pre-pandemic, if you remember the numbers, the time from onset of a behavioral condition and actual diagnosis takes like 7 to 9 years. And that would never happen if you hurt yourself and need physical health care. You wouldn't wait 7 to 9 years to start treating it. But because it happens so often with teens or even preteens, and this starts percolating within them, and maybe they get some treatment as a younger adult. So, but I think the pandemic maybe is bringing that up faster because of the stressors that the pandemic is causing on, like you said, Brian, the younger people, especially, that could have been unemployed or trouble with school or trouble with their families, whatever it is. So yeah, I think great to focus on.
We were already seeing that rise in pediatric mental health issues, and whether it's social media or, right, I mean, this is something we have to really pay close attention to as a society and as a medical community. And now COVID is just going to be exacerbating that and making that worse. So there is an urgency for us to better manage the mental health crisis that we're in right now from a pediatric perspective that we expect to only get worse.
Yeah, for us at Blue Cross, I would say two things. One COVID-related or COVID-associated, and one not. The COVID-associated one is really thinking about telehealth, virtual care, technology, all that together in one piece, and really thinking about where the opportunities are to innovate. As Sherry mentioned, the scalability of this is just so much greater now than it was even 8 months ago because of the COVID crisis. And we should take advantage of this, use this crisis as an opportunity to really think about what we can do differently to really improve the quality of care for our patients and our members. Secondly, outside of COVID, I would say that prior to COVID, one of the largest health problems that we were facing was substance use disorder. It seems like so long ago, but substance use disorder, the opiate crisis, has decreased the life expectancy of Americans for a number of years in a row now. And it's still here. It seems to have been overshadowed by COVID for a short time, but it's not going away anytime soon. So for us in Blue Cross, really thinking about how we tackle that and think about how we can more effectively engage members and patients and think about the collaborative care models and mechanism to really think holistically about individuals with substance use disorder is really critical. Harkening back to one of the points you made very early on, Steve, about the additional economic costs due to substance use disorder. You talked about the economic burden with respect to the healthcare burden, dollars that are spent in health. That doesn't even begin to touch the economic burden, the indirect cost to society, whether it be the justice or families or just or death or premature death for individuals. So really focusing and not forgetting that there still is an opiate crisis is critical for Blue Cross to focus on.
Okay, so we have a few questions coming in, and I want to stay in our time schedule if possible. So the first question, do we think that health plans will be able to incorporate new incentive programs for both provider incentives and also expanding into their members? I'm not quite sure I followed the second part of that question, but new incentive programs. So we think health plans will do that for integrated care.
Yeah, I think the answer is yes. And I think there's going to be a need and a demand from our members to, quite frankly, to innovate in this space. One of the things I referred to earlier was this idea of Blue Premier Behavioral Health, and really thinking about not just paying in a fee-for-service world, but thinking about the additional incentives that you put on top of encouraging providers to do things differently. So the payment is just one piece, though, I would say, that economic incentives are important, but you also need those enablement strategies and tools to really put in the hand of providers to really to make the connections, to encourage the integration. And again, classic example here, or the example I like to highlight, I'm not sure it's classic yet, but I hope it will become the classic example, is the idea where Sherry at Quartet is working really closely with Brian at WKCC to really integrate physical behavioral health. So again, if financial incentives are important, really think about those enablement strategies and tools as well.
So we have another question. So if you integrate care, what measures do you put in place to be able to tell if you're achieving your quality objectives? How do you actually measure for quality improvements of putting behavioral health care services in with primary care?
Yeah, I mean, I think across specialties, across medicine, the questions around what quality measures can you look at that really assesses the performance and the value of a provider. It's always a challenge. For this, though, I mean, for behavioral health, at least from a primary care perspective, you can make it relatively simple. Number one, are you screening for the diseases you should be screening for? So, you have the PHQ-9, you have the GAD-7. Are you actually screening for these? Number two, if you're screening for them, are you treating them? Are you seeing these scores come down? And there's some, and you can retest and see, okay, is there, are you being effective in terms of your treatment? And then because collaboration is so key, not only in behavioral health, but just across value-based care and across population health, access, follow-up would be kind of key components as well. Well, the one thing I think we have to be careful about, though, and this is especially true with behavioral health, when we measure quality, when we're trying to say, okay, these psychiatrists or these primary care are doing well and are high value because of how they're managing their patients. The one thing that we're seeing is continued studies that do demonstrate that this push toward value could be worsening healthcare disparities by incentivizing providers from steering away from more complicated patients with socioeconomic barriers. So often it's the socioeconomic barriers that lead to bad outcomes, and those aren't really accounted for in quality measures. I think that's really true from a behavioral health perspective. So a suburban practice, a psychiatry practice might be a lot different from an inner city practice and the stressors that the patients that they're caring for are managing. So as we develop quality measures around behavioral health, we have to be very careful to make sure that we're not penalizing providers who are engaging poor patients or patients with more socioeconomic barriers to their care.
Definitely. I'd love to chime in there. And Brian, those are great points. I'm also thinking about in these models, it's really important to make sure that patients who have much more acute behavioral health conditions who, you might not see on standardized metrics as much or as consistent improvement. I mean, some mental health conditions are cyclical, or there's episodes of kind of exacerbations of symptoms, and we have to make sure that providers aren't penalized for these patients not consistently kind of reaching improvement metrics. So there has to be some way to kind of weight things so that people are really incentivized to treat high-need and high-risk patients. We definitely want patients to be getting better, but there has to be a fair way to be able to evaluate that. And also metrics that are really meaningful to patients as well. Things like, involvement in their social worlds, ability to work, ability to go to school, relationships with families. And those things in behavioral health are much more challenging to measure than like glucose levels. So it's challenging.
So we talked a little bit about trying to get in front of the pandemic effects on kids and young adults, et cetera, becoming more proactive, predictive models, et cetera. What do you say to a payer, a health plan that says, okay, so you want me to spend more now because I'm going to save money down the road, 3 years from now, 5 years from now, whatever, but I no longer have that person as an insured, somebody else does because of movement in the industry. How do you answer that question?
Well, how do you answer it nicely? Or, well,
anybody want to answer it?
Yeah, but I'll tell you what. I mean, obviously the kumbaya answer. It's the right thing to do for patients. It's going to reduce the immediate suffering, and your job isn't simply to make money. It's to help your clients get healthier. But that's a huge issue, right? Especially from a pediatric mental health perspective. I do think larger payers, including Blue Cross North Carolina, realize, well, they're probably going to be the payer, because they are the biggest payer in North Carolina, that there is a long-term ROI for them as well, that there's a good chance these same patients are going to be, insured by them down the road. So I think that's easier to do with larger payers, but with smaller payers, it is tough. You kind of have to, reference it's the right thing to do for patients, but a lot of times that will get ignored if the financial ROI isn't perceived.
I think it's such a good question. I think it really calls for people to reinvent the way we look at this, because, you know, it speaks to the importance of preventative care, and it speaks to the importance of healthy communities, and that it is challenging to put a dollar sign on that, but it does take time. So if a whole community is doing it, if there's multi-payer alignment in value-based care, over time, healthcare costs will go down, and we'll have healthier people. Yes.
So I realize that in the East Coast, we're into the dinner hour, and we're starting to go over a little bit. We have a couple more questions. Do the speakers want to continue to answer these last couple of questions? Attendees, of course, you can drop off whenever you would like to, but do you want to take 5 more minutes and hit 2 more questions? Not hands. Okay.
Yeah.
Okay.
Sounds good.
So this may more be a question for state governors or something, but when you have a lot of rural areas in your coverage zones, people that live in rural or frontier areas that are in your insured plan, maybe they don't have access, well, they might have no access to integrated care in person, and they might also have trouble with telehealth access and, you know, having cables in the ground where they need to be, et cetera. How do you try to solve those problems when access in any form is really challenging? Any thoughts?
Yeah, maybe I can comment here. So, you know, as we think about that, as we think about North Carolina specifically, large rural populations in addition to a number of urban centers as well. I think the comment Sherry made early on is really astute here, where when you think about virtual care, there actually may be some places, some exceptions where telephonic makes sense. Like even in these rural areas, there's good telephone coverage, maybe not cell phone, but good landline coverage. And that may be the option for a segment of the population. And then also there's an idea of like the idea of a hub and spoke system as well, and appropriately triaging individuals to the right level of care as necessary, and making sure that you can identify those individuals who might need a certain level of care and connecting them. And then subsequently, if they do need to go to a tertiary referral center for an in-person visit, making that connection. But many may actually be able to do it, may be able to get services which is much lower level of service.
Okay, another question. Integrated care may have its own challenges for execution in a fee-for-service system. Payment reform is likely helpful, if not necessary, to encourage this to work financially and clinically as well. Movements to ACO models for providers and health systems. What are all your thoughts about payment models? What are the right payment models? And if we don't have them now, what would they look like?
Yeah, I think, yeah, Yvonne, you're probably better to speak on this than I am, but it's really hard to efficiently address mental health in a fee-for-service model unless you really, I guess, change significantly the fee-for-service setup. And I think that explains why historically, like, I mean, Steve, you just think about your study, that those are crazy results, right? I mean, the cost associated with failing to control mental illness is incredible. But in a fee-for-service world, as a provider, you don't feel that. In fact, it feeds the system. It feeds the cost. If you're profiting off the cost, you're profiting off those hospitalizations, you're profiting off those office visits. And so it's just it just represents a lot of the issues historically with fee-for-service, where we get paid for quantity, not actually keeping patients healthy. I know in North Carolina, the movement toward value is happening quick enough that people across the board are looking up and realizing really it's probably the first thing on the to-do list with mental health, with population health and value-based care, is to get better at this, get better at addressing mental health, because you're not going to be able to control your cost if you don't do that. But and Vaughn might add some other, I just think in models that are not as further along or as not as far along in value-based care, I just imagine it's going to be really tough to do this with fee-for-service unless you significantly change it up. I mean, so many of the issues that we saw in the last couple of years is the access dwindled because a lot of therapists and psychiatrists were just doing cash pay. They just stopped taking insurance completely. Mm-hmm. And so you had a system where people who could afford it were getting mental health care, and the people who couldn't, there was really no option for them. And so I'm sure there's solutions out there. I just think it'd be really difficult if it doesn't mainly involve going from fee-for-service toward value-based care.
Yeah, I think what I might add to that is when you think about payment, you probably need a variety of different approaches. And so let me sort of go back to some of the numbers you presented early on, Steve. So you said that 25% of sort of the population you surveyed had some sort of behavioral health diagnosis. And what that says to me is that some of it's minor, some of it's severe, but it's really prevalent. And as you think about that, an ACO arrangement where primary care providers are the frontline providers really encountering these patients is really critical. And thinking about how do we provide the right service and right incentives and right payment for frontline primary care providers to do what they can. And then there's a subsegment of the population who has severe disease, right? And then you might go to a specialty model. And again, harkening back to the numbers you brought up at the beginning, 10% of the population accounts for 70% of the cost. And within that 10%, half of those individuals have behavioral health. So clearly a subsegment with disease that has severe outcomes of different sorts. And it might be substance use disorder, or it might be severe mental illness. And that might be a disease process that is better dealt with a specialty model, with a certain type of provider. And so really thinking about how you incentivize psychiatrists and sort of that specialty model to really hone in on that patient population. So again, once again, I'll point out though that we tend to focus on payment models, but don't forget about the enablement strategies. What are those tools that you have to make this work? And this is where Quartet is so critical and so valuable, because it's so hard to sort of understand who might even need to identify that 25% of the population without being able to look at the data, without looking at the predictive analytics. And this is where Sherry and Quartet are so critical to the idea of the payment model as well.
Yeah. I completely agree. Mental health and the stigma around mental health buries mental health very deep. And it's going to be hard to identify without the utilization of these analytics. It's essential, and it's huge, and it's doable. And I think Quartet and Blue Cross, at least Blue Cross North Carolina through Quartet, have implemented it and are rolling that out to the primary care docs. But it's absolutely an essential component of this because we're not going to get there without it.
So if we do a great job increasing screening, identifying patients that have underlying behavioral disorders that are now just coming to the surface, maybe thanks to the pandemic or whatever, is it possible that you'll have no place to refer those that need treatment by a behavioral specialist? And if you've got no place to refer them to because of supply, what do you do?
Yes, it is possible, and it probably would happen. I mean, so one of the things that you do, and one of our strategies as an ACO, is manage what you can in the primary care setting. And still, even with Quartet, and even with all this, the vast majority is still going to be managed and is being managed by primary care docs. So part of this is, yes, better integrated care models, predictive analytics, telemedicine, but some of it is also just empowering the physicians. And there is, with Quartet, there's kind of a curbside option where you can, if I can't get someone in to see a psychiatrist, at least maybe I can just run it past them. If I had a quick question like, this patient's on lithium, what do I do with this level? You know, would you change it? So there's probably ways to address that. And a lot of times when we refer from a primary care perspective to a specialist, it very much is one or two questions. What do I do for this? Or what's the next step for this? So there's a way to more efficiently get at that through curbside, text, whatever it is. I think that would be beneficial. But your question is accurate, because the supply, if we truly do this well, the demand will saturate the supply. And so a lot of that is going to have to be somehow to empower our primary care docs to do this better. And that is a challenge.
I think it also takes being able to really take a good look at the networks that we have available. First looking, and this is work that we do at Quartet, being able to take a look at, in a specific market or region, who the patients are and what their needs are, and then going out and doing a full kind of landscape analysis around the mental health providers available in that area, and being able to, recruit and onboard and fill gaps, and being able to make sure that we have the care options needed. And then, like Brian was saying, have patients who can be treated in primary care be treated in primary care. Have patients that can be treated with digital care options be treated with digital care options. Really preserving the specialists for the most acute patients who are in need, and then having, just making sure patients get to the right place. So we're preserving options for the patients who really need it.
Okay, and I think I have the very last question. I think we've covered them all except this one. Do you think CMS is likely to focus on incorporating new quality measures that might have to do with this? And if so, what would they look like? And do we think a platform such as Quartet would be able to help achieve those quality measures?
I think they would probably look like I think they'd start with pretty foundational stuff. So probably the screening, PHQ-9, GAD-7 type screenings, tracking both the screening and then the outcomes with those scores. A lot of the Medicare quality measures are still kind of chart review. So I haven't looked into this heavily, but I would imagine that those are probably what we'll see. Maybe substance abuse, I'm not sure, but I think those are probably the measures that we're going to be looking at.
Any other thoughts? Hearing none, I want to thank Sherry, Vaughn, and Brian as our truly expert panelists, and thank you to the attendees for joining us. And I hope you found that this session was very useful for you.